Most common causes are diabetes, hypertension, and glomerular disease. Kidneys normally excrete nitrogenous waste product in urine. In chronic renal failure, kidneys won't be able to do that, resulting in increased nitrogenous waste product in blood. Patients have nausea, anorexia, pericarditis, platelet dysfunction, altered sensorium with flapping, tremors, and deposition of urate crystals in skin. Uremic pericarditis will present as frictional pericardial rub. Uremic platelet dysfunction will be qualitative, not quantitative. In other words, platelet count will be normal, but patient have increased bleeding tendency. Patient will present with nosebleed or petechiae. In chronic renal failure, kidneys won't be able to filter salt and water. Therefore, there will be salt and water retention with resultant hypertension. In chronic renal failure, there will be decreased functional nephron, won't be able to excrete potassium, leading to hyperkalemia and chronic renal failure patients. In chronic renal failure, there will be decreased functional nephron, won't be able to excrete hydrogen ions in form of ammonium ion and titrable acid, leading to accumulation of hydrogen ion, causing metabolic acidosis in chronic renal failure patient. Erythropoietin is normally produced by kidneys and liver. In chronic renal failure, there will be decreased erythropoietin production by renal peritubular interstitial cells, leading to normocytic normochromic anemia. In chronic renal failure, there is hypocalcemia due to decreased alpha-1 hydroxylation of vitamin D by proximal renal tubule cells and hyperphosphatemia. As we all know, vitamin D is activated by 1-alpha hydroxylase in kidney. In chronic renal failure, there will be no activation of vitamin D, leading to hypocalcemia. In chronic renal failure, there will be hyperphosphatemia. Phosphate binds the calcium, leading to hypocalcemia in chronic renal failure patient. As we all know, hypocalcemia stimulates parathyroid gland to secrete PTH. Raised PTH level will act on osteoclasts to increase bone resorption, leading to renal osteodystrophy in chronic renal failure patients. So there will be secondary hyperparathyroidism in chronic renal failure patients. Vitamin D deficiency due to any other cause will lead to hypocalcemia and hypophosphatemia, but vitamin D deficiency due to chronic renal failure will result in hypocalcemia and hyperphosphatemia because kidneys won't be able to excrete extra phosphate, leading to accumulation of phosphate causing hyperphosphatemia in chronic renal failure patients. Treatment of chronic renal failure involves dialysis or renal transplant. A 65-year-old female with CKD stage 4 has normochromic normocytic anemia with hemoglobin 9.2. Reticulocyte count is low. As we all know, in chronic renal failure patients, there will be decreased production of erythropoietin by renal peritubular fibroblasts, leading to decreased production of erythropoietin. Patient will present with normocytic normochromic anemia with low reticulocyte count. Hemolysis due to oxidative stress will be seen in G6PD deficiency patients. Bone marrow suppression will be seen in aplastic anemia. A 62-year-old man with stage 4 CKD has hypocalcemia, hyperphosphatemia, and elevated PTH. Which of the following best describe this pattern of mineral metabolism abnormalities? As we all know, in chronic renal failure, there will be hypocalcemia due to decreased alpha 1 hydroxylation of vitamin D and hyperphosphatemia. High phosphate binds calcium, leading to hypocalcemia. Hypocalcemia stimulates parathyroid gland to secrete PTH. PTH act on osteoclasts to increase bone resorption, leading to bone pain in chronic renal failure patient. Thus, we see renal osteodystrophy due to secondary hyperparathyroidism. In primary hyperparathyroidism, we will see hypercalcemia, not hypocalcemia. A 58-year-old man with long-standing type 2 diabetes presents with fatigue and bone pain. Lab shows high CREAT, low calcium, high phosphate, and elevated PTH. As we all know, in chronic renal failure patient, we see hypocalcemia due to two reasons: decreased alpha 1 hydroxylation of vitamin D and hyperphosphatemia. High phosphate bind calcium, leading to hypocalcemia. Hypocalcemia stimulates parathyroid gland to secrete PTH. PTH acts on osteoclasts to increase bone resorption. Thus, patient present with bone pain. Fatigue in this patient is due to normocytic normochromic anemia by decreased production of erythropoietin by peritubural fibroblast. Primary hyperparathyroidism will present with high PTH and hypercalcemia, not hypocalcemia. Ectopic PTH production will be seen in renal cell carcinoma. We will see vitamin D intoxication due to excessive supplementation or patient with sarcoidosis, because in sarcoidosis there is increased activity of alpha 1 hydroxylase, leading to activation of vitamin D, causing hypercalcemia, not hypocalcemia. A patient with advanced CKD develops metabolic acidosis. As we all know, in CKD there are reduced functional nephron, so hydrogen ions will not be excreted as ammonium and tartrable acid. Retention of hydrogen ions will lead to normal anion gap metabolic acidosis in chronic renal failure patients. Urine analysis in a patient with end-stage kidney disease shows broad waxy cast. Which of the following best describes the origin of these casts? These broad waxy casts arises from dilated collecting tubules with TAM horseful protein in chronic renal failure. As we all know, fatty cast will be seen in nephrotic syndrome. RBC cast will be seen in nephritic syndrome. Muddy brown granular cast will be seen in acute tubular necrosis. Hyaline cast will be seen in pre-renal azotemia. WBC cast will be seen in acute interstitial nephritis and pyelonephritis. 72-year-old man with CKD presents with pruritus, pericardial friction rub, and flapping tremors. Which of the following uremic complication is most directly reasonable for his pericardial frictional rub? As we all know, in CKD, accumulation of nitrogenous waste product will result in uremia, causing pericardial frictional rub, pruritus, flapping tremors, nausea, and anorexia. In a 55-year-old female with CKD progresses from stage 3 to stage 5 over several years. Which of the following laboratory changes is most characteristic of transition to advanced or end stage CKD? In early CKD, fibroblast growth factor 23 rises to promote phosphate excretion, but in advanced CKD, fibroblast growth factor 23 rises early to promote phosphate excretion but becomes ineffective, leading to persistent hyperphosphatemia despite very high fibroblast growth factor 23 and secondary hyperparathyroidism.